Good afternoon, everyone. Thank you, Narendra. And thank you, Murli. That was an extensive talk. You covered a little bit of my talk also. My talk is on why anti-VEGF therapy fails and what to do if it fails. First of all, as we all know, anti-VEGF therapy is the mainstay or the gold standard for managing patients with wet AMD. The response rate in published studies ranges from 70 to 95%, that is stabilization or improvement of vision. The response rate also depends on the agent used and the treatment paradigm used. That is whether you are going for a PRN based treatment or a loading dose regimen or a loading dose plus extend therapy. Some patients, in spite of your best efforts, they do fail treatment and they represent the most challenging cases. What is a treatment failure? There is no universally agreed upon definition as a treatment failure. You have a definition for wet AMD but no definition for a treatment failure. But broadly, you can say that there is a treatment failure when multiple anti-VEGF treatments have been applied and fluid or leakage is still persisting on OCT or an angiography, or when vision loss continues despite a course of treatment. You have given your treatment but still the patient is losing vision, or when continuous monthly injections are required to keep the macula dry. That is, you stop the treatment, the patient is worsening again, so you'll have to give some more injections, or where the treatment produces a decrease in edema but no improvement in final visual acuity. Factors affecting the treatment failures are, if it is a large wet AMD, the response would be bad. The bigger the lesion, the lesser the response. Also, initial reading ability. The lower the initial reading ability, the chance of responding appears to be reduced. Treatment protocol also may affect the response rate, like whether you are doing a PRN based or a loading dose regimen. The treatment protocol also has a role. We'll not go into theory, but I'll show some cases where I myself personally failed and corrected myself. So this was a male patient, 72 years old. Other eye, there was a large scarred CNVM. He came with blurring of vision of more than 6 months duration. Visual acuity was 636 and 18. Angiographically, there was a PED-like lesion here, and OCT showed a PED with a serous detachment. He was diagnosed elsewhere also as wet AMD, so we continued the same diagnosis of wet AMD. We have occult CNVM and we have advised anti-VEGF therapy. He chose 3 injections, Avastin, loading dose regimen at monthly intervals. This is what happened. After the first injection of Avastin, it was the same. After the second injection of Avastin, it was the same. After the third injection of Avastin also, it was the same. 1 month post third injection, absolutely there was no change in either. The visual acuity has improved by 2 lines, but clinically OCT features, there was no change. Then this PED is called as a double hump PED. This PED is typically seen in patients with polyps, IPCV. So we thought we'll rule out IPCV. We did an ICG. ICG did not show any polyps. So there was no response to Avastin, but there was 2-line improvement in visual acuity. So we plan to extend the treatment and give him 2 more injections. This is after the 4th injection, vision is the same, serous detachment is the same. After the 5th injection, it is again the same, and 1 month post 5th injection it is same. 6 months post the 5th injection of Avastin also it was the same. There was absolutely no change in OCT picture. So where did we go wrong? This is a series OCT. What did we miss? In fact, what we missed was the correct diagnosis. It was a wrong diagnosis. This patient did not have wet AMD, but it was a sick RPE syndrome. The PED and a serous detachment, previous history of a diagnosis of wet AMD misled us. So this was not a wet AMD but a sick RPE syndrome, and the fluid, that's why it did not regress. Then in a take home message, if a patient is not responding to your treatment in spite of your diagnosis of an AMD and continuation of the treatment, recheck your diagnosis. This is another patient, a female patient, 52 years old female patient with defective vision in the left eye since 6 months duration. Systemic illness, nothing. She was perfectly fine. Visual acuity in the right eye was perfectly fine. Left eye was 660 N18. Clinically, fundus picture was this. She had exudate and a large PED temporal to the macula. Angiographically, a fibrovascular PED. Classical diagnosis of an occult CNVM. And OCT also showed a huge PED with serous detachment. So this diagnosis was confirmed that it was an occult CNVM. We advised anti-VEGF therapy. Patient chose Lucentis. This was after the first injection of Lucentis. This was after the second injection of Lucentis. After the third injection of Lucentis. Absolutely not responding. In fact, if you can see, the hard exudates are increasing. The exudates around the macula were increasing. The serous detachment was slightly increasing. And visual acuity was the same, 3 meters. So, post 3 injection, worse vision and also exudate is worsening, PED is increasing. So, where did we go wrong? We thought again this might be a PCV polyp, and then we did an ICG. ICG did not identify any classical polyps, but only there was a dilated vessel. In literature, when you see, most of the Japanese studies show ICG features of polyp as a branching vascular network and not as a pinpoint leakage as we see in the Indian subset. We had published a paper in IJO in 2010 analyzing IPCV patients where this branching vascular network was very rarely seen. Out of the 42 patients which we published, only one had a branching vascular network, and this was that patient. So we thought there is no IPCV, no classical polyps, so extend the treatment. After the 4th injection of Lucentis, vision slightly improved to 660. After the 5th injection of Lucentis, PED decreased, but if you see here, this side it started developing PED. So one side PED is coming down and the other side PED is increasing. She had improved in visual acuity to 618 because subfoveal, the edema has decreased and the serous detachment has gone. So after the 5th injection, after 7 months, she came with a massive bleed temporal to the macula and again recurrence. But she was maintaining a good visual acuity. So when we discussed with some of our colleagues, they said that it can be a variant of PCV. Why don't you do a PDT or a laser to the dilated and tortuous vessel? So what we did was, we thought we'll do a combo therapy, and we did an injection Avastin. Patient was totally tired of Lucentis injections. He said, I don't want any more Lucentis, I want a cheaper treatment. So we thought we'll give an Avastin with a thermal laser because the dilated vessel was away from the macula. So we gave an Avastin, and 2 weeks later we did focal laser to the dilated vessel. And she landed up with a massive subretinal hemorrhage. Where the PED was there, nasal to the macula, there she developed a huge, the PED increased a lot and she developed a subretinal hemorrhage. So we stopped the treatment there because laser, thermal laser in IPCV, at least it takes anywhere between 8 weeks to 3 months time. So we said we'll stop the treatment, and surprisingly 1 month after the second injection of Avastin was given, PED started coming down and OCT also flattened out. So we kept the patient on observation. The hemorrhage slowly started absorbing. We repeated the ICG. ICG again did not show anything except dilated vessels in the subfoveal area. Then there was still some improvement, so we stopped injecting the patient and we observed it. So this is the sequence of events: PED not improving, then again worsening on one side, then change to treatment, and finally this patient stabilized at 624 N18 after 1.5 years of treatment. So here what I would like to emphasize is that in non-responders, in spite of your treatment, if they are not responding, then suspect coexisting conditions like IPCV, polyps. Polyps are known to occur in up to 28 to 54% of patients with occult CNVM. So if a patient with an occult CNVM, it is not responding, ideally you should do an ICG to rule out polyp. Again, this patient, we switched over from one therapy to another therapy. So In non-responders, do you need to switch over to therapy from one drug to another drug? That is another question. This is our third patient who was a 79 years old male patient, one-eyed patient. The other eye he had an injury with a knife 25 years ago and it is blind. Defective vision of 2 months duration. Visual acuity was 6, 9 and N6. He was diagnosed to have a choroidal neovascular membrane. Again elsewhere he came for a second opinion to us. Unfortunately I do not have a fundus photograph or an angiogram, but again a PED, a serous detachment and some retinal edema. So one-eyed patient, we gave him an option. This was in 2008 I think, when there was Macugen. So we gave him Macugen, Avastin and Lucentis option. He chose Macugen, and this is after 3 injections of Macugen. After the first injection, vision same 6-9. After second injection, vision dropped 1 line, PED increased. After the third injection, vision dropped by 1 more line. 6-9 vision became 6-18 and PED increased and a serous detachment also slightly increased. So again we did an ICG. ICG again did not show any polyps. Then clinically patient is worse, vision has decreased. The patient was given the option of switching the drug as there was no response to Macugen. We gave him Lucentis or Avastin. The rationale of switching over therapy at this point of time is because Macugen was a selective anti-VEGF inhibitor, whereas Avastin and Lucentis, they have pan anti-VEGF inhibition. So this was after the first injection of Lucentis. This was after the second injection, serous detachment is gone. After the third injection, vision again recovered to 6, 9 and 6 and patient is happy now. So here what I would like to highlight is that change the management strategy. That means if you are using Macugen, we used to change to Avastin or Lucentis. Combination therapy. If it is a single anti-VEGF agent, give either an anti-VEGF with a steroid or anti-VEGF with PDT or anti-VEGF with thermal laser, especially if you suspect IPCV or polyps with dilated branching network of vessels or polypoid lesions, or extend the therapy. Do not stop the therapy if the patient is not responding. Because of tachyphylaxis, some patients respond late. If it is a smaller lesion, the response would be early, but if it is a larger lesion with lots of edema, lots of exudate and serous detachments, they would require an extended treatment. So in general, if you see, 95% of the patients stabilize or improve after treatment. This is this 5% which are improved. If it is a small lesion, you change the anti-VEGF. If there is good response and the patient improved, you monitor the patient every 4 to 6 weeks and see if there is any relapse. If it is a larger lesion, do a combo therapy. And in spite of changing the anti-VEGF in a smaller lesion, if the patient is not responding, again you can switch over to combo therapy. So in conclusion, recheck your diagnosis, whether your diagnosis is correct or wrong. Second one, check for coexisting conditions like polyps or IPCV. And in third one, try changing the management options to combination therapy or extended therapy or an alternative therapy. Thank you.